Hi, this is Elliot Fishman, and welcome to part 2 of our analysis of carcinoid tumors. In the first part, I went through lots of information with you about carcinoid tumors and their CT appearance, some of the critical findings. We looked at some examples, but in part 2, we're going to look at many more cases. Remember, I showed you a couple cases at the end of part 1, which was small, very bright vascular lesions in the duodenum. Well, here's a nice lesion in the patient's duodenum, third portion. You can see it's vascular, classic for carcinoid, and then there's a mass in the root of the mesentery. And here's that mass in the root of the mesentery, the desmoplastic reaction. That's most classic for a carcinoid tumor. On the MIP imaging, and I always do MIP and volume rendering, you see the portal vein and then the SMV and the SMV occlusion due to the desmoplastic reaction, and all of these collateral vessels are nicely shown. And here's just a few more MIP imaging showing in that as well. Here's a volume rendering showing the tumor in the junction of third and fourth portion of duodenum infiltrating. You could think of adenocarcinoma, you could think of lymphoma as infiltrating tumors, but neither of them are going to be very vascular. So once it's vascular like this, you go with carcinoid tumor. Of course, seeing the mass in the root of the mesentery doesn't hurt my differential diagnosis. Narrowing the window a little bit with volume rendering, really showing the infiltration of the tumor from the third portion of the duodenum, really just into the jejunum. Another example, here's multiple vascular liver metastasis. Neuroendocrine tumor is one of the possibilities, though it could be multifocal hepatoma, metastatic renal cell carcinoma. But then on the image on the right, there's a large mass in the root of the mesentery. The mass has calcification. The mass is in part vascular. When you look at it at the coronal views, you see there's a desmoplastic reaction. When you look at the MIP imaging on your right, the occlusion of the SMV with collateralization very nicely shown. And as you scan downward, you find the patient's primary tumor. Here's a tumor in the terminal ileum. Soft tissue mass, very vascular. Now, adenocarcinomas are not going to be vascular. Lymphomas may be bulkier, but surely aren't vascular. You can have certain small bowel metastasis from a renal cell can be vascular, but typically you're dealing with a carcinoid tumor, very nicely shown in the distal ileum. You can also see carcinoids in the patient's appendix. Just a really nice carcinoid tumor in the patient's terminal ileum. And here's desmoplastic reaction, branch encasement of ileocolic vessels by the soft tissue mass with the desmoplastic reaction, making this a classic carcinoid tumor. And here it is with volume rendering, nicely again, the primary mass in the bowel, as well as the mesenteric mass. Put them both together, classic for carcinoid tumor. Another patient with symptoms of carcinoid, and if you look really hard, there are multiple small vascular lesions in the patient's distal ileum. They're small, right? But they're there. And then you really could see them on the coronal view. Again, thickening of bowel. There's now masses in the mesentery, small 4 millimeter, 3 millimeter lesions in the patient's bowel, which you see very well here as well, and even better. This is a case I remember I showed Dr. Cameron. I thought I made a great diagnosis of a carcinoid tumor, and he didn't mention it to me, and so I looked up the path, and it was a carcinoid. And I mentioned, hey, whatever happened to that case? And he said, oh, yeah. I said, it was a carcinoid. I was right. He goes, well, you said it was a carcinoid, but I found like 10 carcinoids, so you're only 10% right. And this is one of the rules about carcinoid tumors. You need to look very carefully. There can be multiple small lesions present, which is important for the surgeon. Of course, the surgeon will look very carefully when they're at surgery, but it's very helpful for us to tell them in advance. And here's just a few more views of that same patient showing you how extensive and how multiple tiny neuroendocrine tumors or carcinoid tumors there are present here. Another example about that classic mass in the mesentery. This is not sclerosing mesenteritis, desmoplastic reaction, very nicely shown. The calcification, very nicely shown. The stretching of the vessels. Again, here it is on a few additional images. And again, mass in the mesentery. If this was treated lymphoma, could be, but sclerosing mesenteritis, but the desmoplastic reaction from the other images puts this into the category of a carcinoid tumor. Another patient, here's mass in the mesentery with calcification and some desmoplastic reaction. This is a carcinoid tumor, and you could really appreciate it on the coronal view with this desmoplastic reaction, all this beaking and beating and connecting of multiple small bowel loops. In some ways, it looks a little bit like Crohn's disease when you have Crohn's causing fibrofatty proliferation and then the fistula between loops of bowel, but you don't see fibrofatty proliferation here like you see in Crohn's, and the calcification is not something you see in Crohn's, and this is a carcinoid tumor. Same case, the MIP imaging showing you the desmoplastic reaction very nicely off some of the ileocolic branches of the SMA, very nicely shown here as well, and here as well. So again, you can see the primary tumor. Now, one thing with carcinoid tumors, a lot of articles used to say you can see the primary tumor in 30% of cases. It's probably more like 80% with CT enterography or even higher. The key thing is dual phase imaging. Arterial phase is critical because often carcinoid tumors of bowel may be best seen on arterial phase or only seen in arterial phase. Once I see a desmoplastic reaction like this with the calcification, and I know I'm dealing with carcinoid, I will look really carefully because you can see this 1 centimeter circular lesion is very, very easy to walk by. Here it is on the cinematic rendering. We are again, like with many things with cinematic, trying to use cinematic for small bowel, particularly for detecting small lesions like this. And here's just a very nice example. There you can see the SMA, its branches, and that desmoplastic reaction. Really nice carcinoid tumor. And I think the cinematic rendering can be very helpful, but again, I can't quantify its value. Another example, larger mass root of mesentery, right? Vascular. Look at the size of it in the coronal view and look at that desmoplastic reaction. And when you follow it down with the MIP imaging, the stretching of the vessels, that desmoplastic reaction surrounding it right here. And this would be a good look on a cinematic rendering because you see the large mass, you see the desmoplastic reaction. There's not much of a differential diagnosis, just a beautiful example of a desmoplastic reaction in a patient with a carcinoid tumor. And again, look at the little beading around the edges. That's the most classic desmoplastic reaction that you are going to see. Now, sometimes the tumors are small. Again, mass in mesentery, lymphoma treated, a calcified node potentially, but all of the stranding around it, which is that desmoplastic reaction, you're not going to see with lymphoma, and you're not going to see with a node of any other category as well. Again, compared to the other case, it's smaller, but there are actually 2 masses in the mesentery, both of which have calcification. And when you look at the MIP imaging, the desmoplastic reaction is better seen. Now, we try very hard to find the primary tumor. Sometimes you can't. When the surgeons go in, they obviously can palpate. If we can do dotatate scans as a way of looking for primary tumors, which can be helpful. If not, the surgeons will palpate the bowel. And since most of them are in the terminal ileum, they kind of know where to look. But again, very nicely shown here. And in this case, we actually did find the tumor right in the patient's ascending colon. A really, really nice example of that. And here's the same case, the cinematic rendering of that desmoplastic reaction and the masses, the 2 of them, and you can see the branches coming off the SMA, ileocolic branches of what's causing that desmoplastic reaction. And here it is again, some additional images with cinematic rendering. Another example, here's a patient, mass right lower quadrant, enhancing. Again, carcinoid, You think of lymphoma, all possibilities, but the enhancement, more like neuroendocrine tumor. And then here's the primary tumor, the prominent vascularity of that lesion. And you can see it very nicely as we look at the coronal views. This patient's lesion is small, but as you look toward the liver, you see the patient has liver metastasis. So even small carcinoid tumors at times can give early liver metastasis. Again, you need to look very carefully with dual phase imaging at the liver, and if there's any uncertainty, MRI can be helpful. Here's just, again, MIP imaging, subtle lesion. There's the primary tumor. So sometimes it's easy to see, sometimes it's not as easy to see. Sometimes you have to use MIP imaging. You got to do volume rendering. You got to look really carefully if you want to pick up the patient's primary tumors. But here's a nice example of that desmoplastic reaction distally and the occurrence of a 1.5 centimeter primary tumor. Okay? And again, look at the mesentery. When you see the mesenteric mass and you see the small bowel, then you're going to really feel comfortable calling it a carcinoid tumor. And again, playing with the windows, there's the blush, very nicely shown, and there's the primary mass in the mesentery. Now, I mentioned PET can be very helpful. Here you see a mass in the root of the mesentery. Could this be Castleman's disease? Could this be an enlarged node? Does it have to be a carcinoid tumor? You want to look at it more carefully. That ends up being the mass in the mesentery, and the carcinoid tumor is in the right colon. You can see it very nicely here. And here's the mesenteric mass. Here's some additional nodes. You can see the SMA is patent. Replace common hepatic artery off the SMA. And again, the desmoplastic reaction in the bowel. But again, the bowel, it's hard to see the lesion. At times you're going to have to work on it because some of these lesions are a centimeter and less, so you really need a hard time finding them. Here's that node, which is really very, very bright on the PET scan, as well as the patient's tumor in the small bowel. So a nice correlation of CT and PET. And again, here's CT volume rendering on the right and MIP on the left. Sometimes when you're just trying to look for something bright, the MIP imaging is going to be of tremendous value, better than volume rendering or even cinematic rendering at times. So again, another example, you can see the lesion in the terminal ileum. You can see the mass in the mesentery. Very classic for a carcinoid tumor. Okay, no problem. What about this one? Again, small mass, terminal ileum by ileocecal valve, liver metastasis. Again, good for a neuroendocrine tumor, very good for carcinoid. So again, you could see that when we look very carefully, the mesenteric mass probably is the easiest and the fastest thing you find. But then when you really look carefully, you do often, probably better than 80% of the time, will find the patient's primary tumor, as you can see in this case as well. Small bowel carcinoids can also give really thickened bowel, almost like a large desmoplastic reaction. Look at the thickened small bowel in this case. Look at it on the coronal view. Look at the mass in the root of the mesentery with calcification. This makes it easy to suggest that it may be a neuroendocrine tumor, a carcinoid tumor specifically. It's not a small bowel adenocarcinoma. It's not ischemic bowel. The mass in the mesentery with calcification really gives the answer away. And you can see it very, very nicely here. And just a few more images. Again, mesenteric mass, 70% of calcification, thickening of bowel, tethering of bowel, almost looks like a carcinomatosis pattern. You could be fooled if you look quickly. Maybe it's ischemia, maybe it's severe enteritis, maybe it's related to patients on ACE inhibitors. It's all things to think about, but the right answer is that calcified mass in a carcinoid tumor. And then you can see it here as well, right? There's tumor, very bright, almost pushing toward an intussusception. Carcinoid tumors can cause intussusceptions. I should mention that they often don't because the primary tumors are distally and they're very small. But you can see here how difficult it can be. Yes, small bowel is dilated. Yes, it looks like a swirl here. Maybe it's a midgut volvulus, but it's really the bowel being obstructed by the primary tumor with some desmoplastic reaction around the primary tumor. And again, this is shown well as we go to cinematic rendering with the desmoplastic reaction, the tethering of bowel, the dilated bowel, and the transition points, all there as long as you look carefully enough. And here's just one more set of images. So you could see that coronal views, be it with MIP, coronal views, classic volume rendering, or cinematic rendering, all can be very valuable in looking at the bowel pattern, how the bowel is laid out, where the transitions are, and where the masses are present. Okay? Something to think about. Another example here, mass in the mesentery, calcification. There is some desmoplastic reaction, some irregularity of branched vessels of the ileocolic vessels. Again, there's the mass. There's the abnormal vessels. Classic diagnosis, not lymphoma, not Castleman's disease, not tuberculosis. No. This is going to be a carcinoid tumor, very nicely shown with that desmoplastic reaction. Another example, mass in the mesentery, liver metastasis, carcinoid tumor. And you can see the MIP imaging and volume rendering can be very helpful at defining the extent of liver metastasis. And you can occasionally get solitary lesions that are small, but often you'll get large multiple lesions, even though the tumor is not that large. But again, carcinoid tumor, number one place to go that we worry about is going to be the liver. And again, here's that mass, the enhancement. Here's the involvement of the patient's SMV, very classically well shown with the calcifications that are present. Now, this is what we said before, and I wanted to just reinforce. I showed you some examples. I showed you the masses in bowel, typically small bowel, though we did show duodenal masses, and they're vascular. Desmoplastic reaction you don't typically see with duodenal carcinoids, but with the rest of the small bowel, the answer is yes, and they can be very vascular. They can be calcified, which is helpful, but again, sclerosing mesenteritis can also calcify with the same frequency, between 60 and 70%. And of course, looking at the liver, you want to look carefully. The liver mets can be small, but they're going to be hypervascular. Now, when I finished the talk, or I was finishing it, I said, well, let me see how Gemini, which is Google, can do. So here's what statements it gave me. And I'll give you 3 statements to sum up my talk and just refresh everything. Small bowel carcinoid tumors, now more commonly referred to as well-differentiated neuroendocrine tumors, or NETs, present with a classic appearance on CT, though the primary tumor itself is often small and difficult to detect. We agree. The primary tumor often appears as a small, hyperenhancing submucosal mass or polypoid lesion, most commonly in the distal ileum, typically under 2 centimeters, and can easily be missed. We agree. The mesenteric mass is often the most prominent finding and typically manifests as an enhancing soft tissue mass within the mesentery, representing nodal metastasis. And we did say that in almost every carcinoid tumor, I easily see the mesenteric findings. The small bowel itself can be more challenging. We talk about desmoplastic reaction, very important, sunburst, smoke wheel appearance, bowel tethering. We mentioned calcification in 70% of the time, and the desmoplastic reaction affecting vessels. You can see very nicely this article, or the summary, 3 slides from Gemini. I did not edit the Gemini. I just said, tell me about small bowel carcinoid tumors. They gave me a very nice summary that I think is very helpful for you as well. And with that, that's a lot of carcinoid tumors. We see them not that frequently, so it takes a while to collect, but you need to be able to recognize them because, as I said in the beginning, it'll often be between 2 and 5 years from presentation to diagnosis. The sooner we diagnose, the sooner we can treat, and the less likely the patients will get metastasis. And with that, have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.